We are live now.
Good evening, everyone, and welcome to today's evening's webinar. The topic of our webinar is the role of anti-psychotics in the management of schizophrenia and bipolar disorder, where we're looking to balance efficacy and tolerability. The webinar has two parts. One will be a talk by Professor Dr. Christopher Correll on this topic, followed by, of course, a panel discussion where we have 14 eminent consultant psychiatrists from India who will express their views on a molecule called cariprazine and also its effects compared to other antipsychotics. It's my proud privilege to introduce the chairperson for Dr. Correll's session, Professor Dr. Nilesh Shah, professor and head of the Department of Psychiatry at the Lokmanya Tilak Municipal Medical College. Over to you, Dr. Shah.
Good evening, friends. Namaste. I'm very happy to be over here. And I'm very grateful to the organizers of this meeting for giving me this opportunity to chair a session by none other than Professor Correll. Can I have the slide of Dr. Correll's resume? If you look at the slide of Dr. Correll's resume, it is very, very impressive and it is extraordinary. Professor Correll had a training in adult psychiatry as well as in child and adolescent psychiatry. No wonder he is a professor of psychiatry at Zucker School of Medicine in New York, as well as professor and chair in the Department of Child and Adolescent Psychiatry at the University in Berlin. What is most impressive and extraordinary about him is he has more than 800 publications. Yes, you have heard me right. 800 publications which have been cited more than 60,000 times. And he has received more than 40 research awards. Very, very impressive. What is more extraordinary is he has been listed as one of the top 100 most influential scientific minds, top 1% cited scientist in the area of psychiatry, and the #1 world expert in 9 different areas, one of which is also psychopharmacology. Sir, we are very impressed with your extraordinary resume. We are all clinicians over here. We have heard about this new molecule called cariprazine. We have read about it. Some of us or most of us have also used this molecule in the last 6 months since it is available in India. So we would be very, very happy if you can share your personal experience of using this molecule with us. Few questions which we have in our mind are, is it a me too or one more kind of a molecule, or it is something different? If it is different, in what way this molecule is different than other conventional and atypical antipsychotics which we are using otherwise? Are there any specific indications for using this molecule? And if yes, how do we use this molecule? So, sir, over to you, Professor Correll. We welcome you.
Sir, you have been muted. Kindly unmute, sir. Professor Correll, sir, kindly unmute.
Sorry about that. Yeah, thank you very much for the very kind introduction, the kind words, and for setting the scene, asking some of the questions. I didn't know that it was so much practical because I could have brought some cases, but maybe we can do that another time if people feel that the conversation should continue. This is data heavy, but we can then translate that into clinical care during the discussion. How to switch, how to start, what are the preferred patients where you should potentially try this medication first. But let's first see what are the data and how does that fit into the canvas of the other agents? Because you asked, is this just a me too, D2 drug, or are there differences? This is my disclosure information. And this is what I would like to cover with you. First of all, cariprazine. What's the pharmacology? What does it do to the brain? What does the body do to it? So pharmacodynamics and pharmacokinetics. What are the data in schizophrenia? What are the data in bipolar disorder? And how does it fit with meta-analytic data with other medications, both efficacy and tolerability? So let's start with the pharmacology. So cariprazine is a unique molecule from a pharmacokinetic and pharmacodynamic standpoint. Here you see the pharmacokinetics. Actually, cariprazine is 3 drugs in one. That's the top row. It is metabolized into desmethyl, DCAR, desmethylcariprazine, and DDCAR, didesmethylcariprazine. These have similar activity, but different half-lives. And as I'll show you in a minute, the half-life combined is about 1 week. So it's a somewhat depot oral drug, which obviously has implications because patients might miss a dose here or there. This is a very forgiving molecule. It will not really sink the blood level quickly. So if you have someone who's a drug abuser who says, oh, on the weekend, do I take your drug or my drug? The drug holiday, which is obviously our drug that they stop for that weekend when we've told them never mix the two, will not upset the blood level much. So that's a good thing. Will it have a bad side on the side of titration and achieving blood levels? We'll talk about that in a minute. So the overall half-life is about 1 week, but the peak level is after 3 to 8 hours. That means please give it at night because we want people to sleep through the peak. We want people to not have the peak-related side effects. Even though there is a long half-life, there is still a peak and trough. It's highly bound to protein, and it's basically broken down by the cytochrome P453A4, which is the big road in the liver. So not many other drugs will upset it. It's not 2D6 like aripiprazole, risperidone, where there's a lot of pharmacogenomic differences, and there might be more slow or fast metabolizers. So it's easy unless you have ketoconazole on board. Now, we talked about the half-life, 1 week. Remember, 5 half-lives until steady state, but half-lives are not linear. If it were linear, and here you can see 6 milligrams at steady state is about at 110 nanograms per milliliter. If it were linear, the level until 5 weeks would go like this. But it's curvy linear, meaning after 1 week, you already are at 44%, not 20%. 1/5, 1 week out of 5 weeks would be 20%. We're already at 44%. And at 2 weeks, which is 40% of the time, 2 out of 5 weeks, we're already at 75%. So the molecule and the data I will show you have shown their separation from placebo as early as week 1 at the 2 higher doses, 4.5 and 6. With fast titration. And we'll talk about that too. So you can, even though it's a long-acting oral molecule, which if you have someone at steady state, could maybe even be given once or twice a week and still keep the level, or that there are no formal data on that, but at least the pharmacokinetics would allow intermittent checking. You don't need to check every day. But despite that, you can get blood levels at the time where you need it. That's the pharmacokinetic specialty, having a 1 week long-acting oral. The pharmacodynamic specialty is, yes, it's a partial D2 agonist, and we have 3 of them, ABC, aripiprazole, brexpiprazole, cariprazine, similar sub-nanomolar, tight binding to D2, no difference there, but the difference is on D3. So while aripiprazole has about only 50, remember, lower number means tighter binding, yeah, because you have less nanomolar concentration in a Petri dish to occupy 50% of the receptor. So it's half as tight binding for aripiprazole, D3 to D2, and is almost 4 times lower binding for brexpiprazole, but it's 500%, so 5 times tighter binding than D2 for cariprazine. So it's a D3 preferring partial agonist. You may shrug your shoulder and say, who cares? I haven't heard about D3. I know there are 5D receptors, but nobody talked about D3. Why not? Because none of the agents was as tightly binding to to D3 as cariprazine relative to dopamine? It wasn't relevant because they were all similar. But why D3? What does D3 actually mean in the concert of the brain? Well, D3 receptors project from the ventral tegmental area into the prefrontal cortex. And remember, we think that there is an excitation inhibition and stimulation inhibition disbalance in schizophrenia. So we have too much dopamine in the mesolimbic or in the associative striatum, but we have too little dopamine and glutamate in the frontal lobe. So by either partially agonizing or antagonizing D3 tightly, you are then releasing via D1 glutamatergic and dopaminergic drive. So there's a lighting up in the frontal lobe that should predict better efficacy for cognition, or at least not making it worse, and for negative symptoms. And for negative symptoms, I'll show you the data. We have good evidence that this translates into clinical reality. And it also might help with depression, because in the frontal lobe, if you have too little dopamine there, it tones everything down. And you may know that cariprazine is approved for, in the United States, for schizophrenia, bipolar mania, bipolar depression, and since middle of December, also for unipolar depression in combination with antidepressants. So we now have an agent that covers all bases of depression: unipolar, bipolar, acute, and relapse prevention. And that may be partly due to this D3 agonism in addition to D2 agonism. All right, now let's see what the data show. There were 3 pivotal trials in schizophrenia, and every dose in these trials actually separated from placebo in gray. You can see that placebo effects were pretty high, between 12 and even 16 points, and despite that, cariprazine held its own, with separation from baseline between 20 and even 26 points. So it's a robust efficacy at the end of the 6-week studies. In one study, there was risperidone as a comparator. I mean, it's not a fully fledged active control study, but it's a control that this is a valid study. And in the other one, it was aripiprazole 10. When putting all of the data together, you can see that the 4.5 and 6 milligrams roughly equal 4 milligrams of risperidone, and the 1.5 to 3 milligrams to 10 milligrams of aripiprazole. So the 1.5 and 3 are the doses approved for unipolar depression and bipolar depression. Lower doses of antipsychotics get you better antidepressant efficacy. The higher doses, 4.5 and 6, are most likely the ones you should use, especially for your chronically ill schizophrenia patients and when you want good mania efficacy. The studies were conducted with quite aggressive dosing because of the long half-life. So the studies were 1.5 day 1, 3 day 2, 4.5 day 3, 6 milligrams day 4. With that tight dosing, having day 3, 4.5 milligrams, day 4, 6 milligrams, those 2 doses separated at week 1. I tend to titrate every other day unless I use a benzodiazepine or keep olanzapine for the first week in there to have some sedating effect, which then counters the akathisia. So you will see that there's a akathisia signal in this daily updosing, but it's not so much when you actually have a switch paradigm in the outpatient where you actually titrate every week. And in bipolar depression and unipolar depression, the titration was held for 2 weeks before one went from 1.5 to 3. And the slower you titrate with a partial agonist, as you know, the less activation and pseudo-akathisia you get. But bottom line, robust efficacy, even in acutely ill patients at week 6, with separation of the 3 milligrams and 4.5 at week 1. Separation at 1.5 and 3 milligrams at week 2. How does then cariprazine fit into the overarching model here? And you can see that the newer agents and network meta-analyses look a little bit more at the bottom. Why is that? Because the placebo effect was 12 to 16 points. So that the placebo drug difference is shrinking from older to newer drugs. That doesn't mean that these medications are less efficacious, because having a delta from baseline of 20 to even 26 points is what we see, what patients see. We don't see the placebo-controlled delta. Also, network meta-analyses have become a little bit more honest. They added color. If you're colorblind, you can't see this, but look at cariprazine. It has a narrow 95% confidence interval, meaning, wow, these are robust data, correct? Because we have almost 1,000 patients, but the color is red, meaning very low confidence that this is the true number. Why? Because it's mostly placebo-driven where it is. There are very few head-to-head studies that could contribute. So you have to take this with a grain of lithium and say, yes, this is an efficacious drug. It separates from placebo with each of the doses, but most likely it is affected by the placebo effect. This is a very nice analysis that drills down deeper. I've only shown you the PANSS total so far, but here we have also the Marder subfactors. That's why Steve Marder is the first author of this post hoc analysis. And it's driven here, or it's divided by dosing. And you will see for chronic patients, the sweet spot seems to be the 4.5. You have here the effect size at the bottom. And remember, 0.2, a fifth of the standard deviation difference, is small. 0.5 is medium. 0.8 is large. The overall effect size across antipsychotics is about 0.4. Yeah, if you pool all of them together. And you can see here that for total PANSS, 0.5 for the 4.5 milligrams, higher than the other doses. For negative symptoms, even 0.6, again, seems to be, this is not in predominant negative symptom patients. This is driving down negative symptoms while the positive symptoms also are improved. Yeah, these are acute patients. Positive symptoms, 0.5. Disorganized thought, 0.6. And in the meta-analysis here, risperidone and olanzapine are about 0.5. Yeah, so cariprazine can hold its own. Patients were not very excited and hostile. They had to sign a consent form, so you don't see much in terms of change. And they were not selected for being anxious or depressed. That's why you have lower effect sizes. But most likely 4.5 is a good dose for your chronic patients. First episode, maybe more 3, but otherwise for depression, 1.5 to 3. In the negative symptom study, I'll show you 4.5 was also the dose. What I haven't told you yet, the doses went up to 9 in some studies, but the approval is only to 6 because there was no added benefit between 6 and 9, and there were more side effects in that group. So there are safety data until even higher than 9 milligrams, but it's not necessary. All right, that's short term. What about long term? We don't treat patients for 6 weeks. We treat them for 6 months and 6 years. And here you can see very nice, robust reduction in relapse rate, 60% reduction if you have a hazard ratio of 0.4. But we asked ourselves, is the longer half-life really related to a delay in relapse when patients stop the medication? So we looked at 8 different trial programs, all designed the same for relapse prevention. Patients are stabilized on these medications, quetiapine, lorazepam, brexpiprazole, asenapine, paliperidone, iloperidone, lorazepam, all designed the same. They're stabilized, and then they're double-blindly randomized to stay on drug, and here you see only the placebo arm, okay? And you can see on the x-axis how long is the half-life, and on the y-axis, what is the relapse rate after stopping the antipsychotic? And you can see with shorter half-life drugs, 10%, 15%, even 35% of people have relapsed, and it's less than 5% with cariprazine. What about having a 5 or 10% greater relapse on placebo versus drug? How long does that take? And here you see again, half-life on the x-axis. How many weeks does it take until you're 5% worse than drug? And you can see it's between 1 and 4 weeks for the other drugs. It's 6.5 weeks for cariprazine. That's after stopping. How long is the lasting effect? And if you want a 10% difference, it's between 2 and 8 weeks, and it's almost 3 months for cariprazine. So that just tells us the longer half-life actually matters. The drug stays in the system. It doesn't accumulate. The FDA delayed approval because they said, wait a second, you have such a long half-life. show us that it doesn't accumulate. And if you have more people who reach a year or beyond, does it harm the patient? It doesn't. It reaches a steady state, but it's forgiving. When patients stop, you only supervise them twice a week and they are at steady state. They should actually be pretty well monitored or maintained. We don't only look at relapse, we also want stability. So here we looked at how many patients actually achieve 6 months of stability. And here remission means 4 positive and 4 negative symptoms, each no more than mildly severe. And you can see significantly better than placebo, and with an NNT, a number needed to treat, of 6 or 7. Any NNT of less than 10, so single digit, is considered clinically relevant. So here, patients are stabilized for a long time. And functionality that improved during the oral stabilization is also maintained when patients are in the relapse prevention study. This is our network meta-analysis looking at relapse prevention across all agents. And what we found was that overall, they are very similar. Yeah, so there's no statistically significant difference across these agents, including cariprazine oral treatment. So they hold their own. If you find a patient who acutely stabilizes, they will then also be maintained, whether that's aripiprazole, cariprazine, quetiapine, or a long-acting injectable, as long as they take it. These data are obviously somewhat skewed by the fact that patients sign consent forms and are more compliant than others. So in real world, we would think that an oral depot or an injectable depot might somewhat be beneficial for those that are more non-adherent. What about safety? We can't talk just about efficacy. We need to put that into a context of tolerability. And here again, I highlight the 4.5 milligrams because it wasn't only the sweet spot for efficacy, but also for tolerability. You see study completion overall with cariprazine 53%, but almost 3/4, not half, 2/3, I apologize, 2/3 with cariprazine. Looking at adverse effects, any one of them, if you have basically the study disposition, how many stop for adverse effects is less than 10% with the 4.5 milligrams. And let's look at reasons. So basically, first of all, serious adverse effects were very low, 3%, very similar to placebo. So this is background noise. But there's an akathisia risk, and particularly with a higher dose. But that has to do with the fact that it was titrated so quickly. So if you titrate more slowly, you will definitely reduce the akathisia rate, or be my guest and titrate quickly, give something sedating, an antihistamine, a benzo, or overlap for a week with a more sedating antipsychotic. Sedation was very low, EPS generally also low. Prolactin elevation doesn't exist because this is a partial agonist, so it's sexual side effect sparing. Also, weight gain was very limited, and there were no cardiometabolic effects. Let's drill down a little bit more on the akathisia, which may be seen as an Achilles heel, but again, it has to do with the fast titration. It's much lower when you look at the switch studies or the more maintenance data. So you can see that most of it was actually mild, very few were severe, and the discontinuation rate for restlessness was 6% compared to 4% on placebo. What was done? Well, either when it co-occurred with EPS, then an anticholinergic was used. Sometimes the down titration occurred, but basically the unresolved cases were relatively low. 4 out of 61. Generally, this was very manageable. And here the continuous outcomes, you can see no signal for cardiometabolic lipid parameters or glucose, very little weight gain, 0.6 kilograms in the 4.5, overall 1 kilogram versus 0.5, a fifth of a kilogram, so 0.2. No liver function problems, no blood pressure issues, no QTC prolongation. It's actually a QTC neutral drug. What I want to point out is the prolactin. The prolactin elevation was somewhat higher than with placebo. So about 8 points is just by removing the drug, but it's not as strongly reduced as with aripiprazole. So it has less partial agonism, which for some patients might actually be beneficial. Now, you know that side effects are relevant. They are basically the hinge between efficacy and higher order outcomes, because adherence can be affected by tolerability. And you also know that medications need to be paired and flanked by psychoeducation and psychotherapy. So let's put this into context of patients' self-judgment. Here is a questionnaire study of over 400 patients who were asked on a visual analog scale from 0 to 100, how much do these side effects not create a nuisance variable, but impair your functioning? And you can see side effect management and reduction is relevant, because they said between mid-50s to high 60s out of 100, my functioning is impaired by activating and sedating side effects, as well as weight gain and sexual side effects. So we want to balance efficacy and tolerability. And when looking at the network meta-analysis I showed earlier, you can see the further down you are and away from the vertical line, which is placebo, the worse it is. That cariprazine is somewhere in the middle for EPS, which has to do with the fast titration. In my hands, very few people have akathisia or Parkinsonian side effects, but it's certainly not at the bottom where we see first-generation agents and the DONEs. And for QTC and for prolactin elevation, as I showed you, it is basically neutral, whereas aripiprazole actually significantly reduces it. And therefore, you can see that it has more partial agonism, which for some patients is maybe too much, and it's maybe better to have a partial agonist that has it a little bit more dialed down. When we look at not EPS, prolactin, dopamine-related side effects, but weight gain here, no significant higher weight gain than placebo with cariprazine. No sedation, which in the long run can be quite helpful. Patients can function better, particularly also in mood disorders, as we'll see. But in the acute phase, you may have to add a sedating medication for some patients until the full dopamine blockade has unfolded. And for QTC, I already mentioned, it's not prolonging, so you can add it together with other medications. There are actually 5 QTC neutral drugs in an antipsychotic world. It's our 3 partial agonists, ABC, aripiprazole, brexpiprazole, cariprazine. It's lurazidone and paliperidone. Now, one specific unique feature that the other antipsychotics can't claim is that it has really very good efficacy for negative symptoms. First, remember, negative symptoms, we have primary and secondary negative symptoms. So address depression if it's there, social anxiety, substance misuse, and paranoia, which can all lead to secondary negative symptoms. Avoid extrapyramidal symptoms, avoid sedation, avoid weight gain, because if people don't sleep at night and have hypooxygenation, then they also are not very active. And obviously, we want them to be out in the world. Stimulation is important. In the meta-analysis of negative symptom agents by Stefan Leucht's group, there were only 3 that separated from placebo. One was low-dose amisulpride. But amisulpride, as you may know, is 2 drugs in one. It has a right-turning racemic component, which is a 5-HT7 serotonin antagonist. It's an antidepressant. And at low doses, when you don't have the left-turning, the dopamine antagonist agent, do its trick as much. Yes, you can reduce depression. And depression reduction helps secondary negative symptoms. And since it's against placebo, there was also significantly better positive symptoms. So there's pseudo-specificity, and it only works from 50 to 300 milligrams. When you need higher doses of amisulpride, it's washed out, and that's the antipsychotic dose. The other advantage was olanzapine seemed better than haloperidol. Very small doses, 16, a small sample, 16 and 19 patients, but near better antidepressant efficacy, near better positive symptoms, and EPS wasn't even measured. So the only one that doesn't have pseudo-specificity, no delta in depression because patients were not depressed, no delta in positive symptoms, they were stable, is the study I'll show to you in a second, and that is cariprazine versus risperidone, where cariprazine was significantly superior. Patients were predominantly negative symptom patients, at least 2 years of schizophrenia, stable for 6 months, predominant negative symptoms for 6 months, having a high score on the factor score negative symptoms of at least 24, and at least 2 items were moderately severe. Very little symptoms in terms of positive symptoms, stability of these symptoms, no depression, and also no EPS. So a very clean sample. Primary outcome, as both risperidone 4 milligrams and cariprazine 4.5, with a range of 3 to 6 and the same range of 3 to 6 milligrams with risperidone, both improve negative symptoms to a degree, but as early as week 14, significantly better with cariprazine, and that improves further. But you may ask yourself, well, is that really a robust finding? Its negative symptoms can be cut this way or that way. And it actually is. I took the slide out in the interest of time. However you cut it, whatever factor scores you use, it doesn't matter. Cariprazine was superior to risperidone. There was no pseudospecificity. Positive symptoms remained stable in both, almost no difference, 1 point difference. No difference in EPS, no difference in depression. So it was not pseudospecific. But you may ask yourself, how relevant is this point difference? And here's the point that it is relevant. It translated into functional benefits. While it took 14 weeks for cariprazine to be better for negative symptoms than risperidone, it took only 10 weeks for functionality to improve significantly. And that delta seemed to widen that difference over time. And it's not just in one, or when you pool all the different elements together. Patients were not very disturbed and aggressive, they were super stable, but it's actually separately better for self-care, social relationships, and socially useful activities, where we have a lot of deficit in many, many patients. So this is a drug where you can say, compared to standard of care, we see really negative symptom and functional improvement. These patients were on average 10 to 12 years sick already, and still there was this improvement. But here's something else I find really fascinating. While it took 14 weeks for the negative symptoms to separate, it took 14 weeks, it took 10 weeks for the PSP, the blinded raters saw something as early as week 2, 4, 6. Here's a little loss, but other than that, the CGI, the clinical severity of the illness, was already seen as being different very early on. So there's something like a light bulb effect that patients that have been stable but not functioning well, that's seen already very early. So it's clinically relevant, and it seems to encompass the entire illness. Let's shift to mania. Obviously, when talking about bipolar disorder, we need to treat the symptoms, but also the character of the patient, the comorbidities, which are very common in bipolar disorder, both psychiatric and physical, and avoid more physical comorbidities and treat the context. Here's a recent meta-analysis from last year by Taro Kishi, and you can see for mania, cariprazine is over here, is really at the top of the anti-manic agents. Yeah? So very nice separation from placebo. Here are the different studies. Despite, again, quite a robust placebo effect, the doses here separated between 3 and 6, and here they went even up to 12. Again, we don't need to go that high. So 3 to 6 had similar efficacy as 6 to 12, therefore approval for that dose range. Looking at treatment response, cariprazine also in the upper group here, and looking at all-cause discontinuation, which is acceptability, no difference from placebo. So there's no greater dropout despite some side effects. It's very well tolerated. Let's go to bipolar depression. And here, obviously, we don't have as many options available. This is a supra ranking. So you see always the rank. And for MADRS score, lurazidone and olanzapine seemed, as well as quetiapine, were ranked 1, 2, and 3. They were all equal. So second place after these three that share first place is then cariprazine, which was superior to our aripiprazole or ziprasidone. Looking at remission, here it actually had the second rank. Not many studies had reported this, but it's basically second rank after lurazidone, and it holds its own here also against the other treatments. Overall, pretty well tolerated, lower ranking for all these side effects because it's pretty well tolerated, even in those patients that are more sensitive. We know that mood disorder patients are just more sensitive. Now, olanzapine looked pretty good, but there is pseudo-specificity again. Look here, the olanzapine fluoxetine, that's adding an antidepressant to an antipsychotic, had the biggest effect, but there was also for bipolar depression an effect for olanzapine alone. But what effect is it? Look at olanzapine alone and placebo. Not on apparent sadness, not on reported sadness, but inattention, reduced sleep, and appetite. Based on 3 side effects, there is an overall improvement in bipolar depression. And that's not happening with cariprazine. It's not sedating. It doesn't cause much weight gain. Therefore, we have a drug that actually treats the mood itself. So we have to always be careful when looking at total sum score because it could be driven by side effects. Again, no difference in pessimistic thoughts for olanzapine, that is, inability to feel. And here are the data for cariprazine, where the 1.5 milligram most consistently drove down bipolar depression. In one study, 3, in the other 2 studies, not so much. And that was the same for unipolar depression, where in one study, 2 to 4.5 milligrams was significant for unipolar depression, but in another study, 3 milligrams was not. So lower doses, keep them longer, may actually be beneficial for unipolar or bipolar depression. And since it takes a while to build up, don't titrate up too quickly because, you know, internally it will also increase the level over time. And here are the data looking at, you know, that DSM-5 now has mixed features. So you have depression with some manic features in there. And cariprazine nicely separates whether or not you have pure depression, bipolar depression, without mixed features, manic symptoms in there, or the opposite when you do have it. And here you see the starting dose and the recommended dose. So in schizophrenia, bipolar mania, bipolar depression, and unipolar depression, you always start at 1.5, and then you can go up to 6 in mania or schizophrenia, and you can go up to 3 maximum for either unipolar or bipolar depression. What were the side effects with these agents in bipolar depression? Remember, these are patients who have dark-colored glasses, feel really impaired, and every side effect is aggravated. But overall, pretty good separation from, for example, quetiapine with more weight gain. So it's in the low weight gain range. And there was akathisia, but not up to 18% we saw with 6 milligrams in schizophrenia. 6 to 10%, most of it also transient and mildly. Restlessness can happen initially. Insomnia also, usually single digits. So that's obviously much less somnolence and weight gain than we see with some of the other agents. We talked already about the dosing. Just to reinforce that, there are 4 doses that are available: 1.5, 3, 4.5, and 6. And the titration depends on the level of severity, acuity, and also the setting. So the slow titration would be 1.5 milligrams. And then in an outpatient setting, when you switch, you go up maybe once a week in schizophrenia, and you wait at least 2 weeks for the mood disorder, the bipolar depression and unipolar depression. And in fast titration, you can go up once a day or every other day in the inpatient setting, where you can also respond to some of the side effects that might occur. So let me sum up. Cariprazine has shown good acute and maintenance efficacy in people with both schizophrenia, with bipolar mania, as well as bipolar depression. It has shown particular benefits for negative symptoms as well as functionality. It's a partial D2, D3 agonist, and it's not just a me2, D2 antipsychotic. As always with partial agonists, if the dose is too high, it can cause restlessness. That might be self-limited and pseudoakathisia. We can address that with a benzo very easily, or with slowing down the titration. There can be rebound phenomena when you switch from tight D2-based agents and you liberate that. You have upregulated receptors, the partial agonism hits it, so slow down that cross-titration. The same when you come from the penes and they're very sedating and you come to a less sedating, slow down the cross-titration. Or you come from shorter half-life drugs, which are all shorter than cariprazine, where you also want to slow down the cross-titration. If you go fast, that's fine, but then use something sedating in between. And I think we should put a greater emphasis on functioning and schizophrenia, also negative symptoms, as well as the efficacy tolerability balance, where cariprazine is another agent in your toolbox that you should consider for some of your patients, particularly the younger ones, those that respond well, that have negative symptoms, or where functionality is relevant and you want a weight gain sparing, a sexual side effect sparing drug. So let me thank you for your attention and point you to our COVID study, and maybe you can participate and send it around. More than 185,000 people from, actually that should be 156 countries. I don't know what happened here, 156 countries, but India being the second largest country on earth, we have less than 1,000. In Germany, we have 16,000 who have participated, 13,000, 14,000 in Thailand. So www.COVID, COHFIT, to stay fit during COVID, that would be great. If you, takes about 35 minutes, it's long, but it helps us help others, how we can deal with the pandemic better. Thank you, and I look forward to our discussion.
Dr. Shah, I think if there are no questions in the chat box, so what we can do is, I think we, for want of time, we'll move to the next aspect, which is our panel discussion.
Yes.
Well, good evening, everyone, and I'm your moderator for the evening. We will start with our panel discussion, and if there are any questions that come up in the chat box for Dr. Correa, we'll take them up towards the end of the program. The questions that I have for the panelists are...
Avinash, there is one question. What do we mean by pseudo-specificity, sir?
Yes, so please answer, sir.
Yes, thank you very much. This is a term that the FDA, the Food and Drug Administration, likes to use, and that is when you see a reduction in negative symptoms, but it's really not the negative symptoms that improve, it's because the positive symptoms or the depression improves. So let's think of a patient who is bombarded by hallucinations, thinks that people are out to get him. He'll be very withdrawn, not smile much. Once the delusion goes down and he's not as tense anymore, he's going to talk to people and smile a little bit better. And then this improvement in negative symptoms is pseudo-specific because it's dependent on the positive symptom reduction. Same when you improve positive symptoms in thought disorder, your cognition will improve to a degree. So you need to have patients who are really free of depression, free of positive symptoms, free of EPS, so that there can be no change that drives secondarily the negative symptoms or cognition or what have you.
Thank you, sir, for answering that. We'll now move to our panel discussion. I will introduce each panelist and then ask the questions, so that will be better, so that Dr. Correll and the others would also know the panelists one by one as we go along. My first question is to Dr. P.N. Suresh Kumar. Dr. P.N. Suresh Kumar is a consultant psychiatrist practicing at Kozhikode. He's also recently been awarded the IAPP Best Case Conference Award at our conference. So very simple question to you is, after you heard Dr. Correll's talk, you also used cariprazine in your practice. Do you feel between bipolar disorder and schizophrenia, where do you think cariprazine stands out better? In which disorder do you think it works better from your clinical experience?
For me, in my practice, the most difficult situation is for treating negative symptoms and cognitive symptoms, because we have got enough antipsychotics that will take care of positive symptoms. So we are in a dilemma how to treat patient, how to become a schizophrenic patient fully functional. So here, I think we have tried many patients. I have added cariprazine along with the primary antipsychotic. So see, or I have used this drug only for the last 2 or 3 months. So some in my clinical experience, I have seen some, I don't know whether it is statistically significant or not, but there is definitely an improvement in cognitive symptoms as well as negative symptoms when we are adding cariprazine with the primary antipsychotics. But I have a question that when we are adding cariprazine along with the primary antipsychotic, which is the best antipsychotic, primary antipsychotic to be added with the cariprazine?
So we will come back to that question as we go through the panel, because those are part of the issues that we will address. I'll definitely take this up in the end. My next question is to Dr. Navi Kiran Mahajan. Madam is a professor at the Department of Psychiatry at the Dayanand Medical College, Ludhiana. Ma'am, my question to you is, do you think cariprazine has a role in patients with major depression that may have psychotic features? Particularly when we are using antidepressants in them, but we find there are psychotic features which are also there. Because of its pharmacology, do you think there's some role of cariprazine in that group?
Thank you, Dr. Avinash. So personally, I feel since for the first time we are having an antipsychotic with such a broad spectrum of efficacy, so although I don't think the literature per se for major depression with psychotic features does exist, but the kind of experience that we are seeing that people are having and the kind of approvals we've already gotten and the experience with add-on in major depressive disorder per se, so I think it would be worthwhile looking at in the long term, because I have already started using it as an add-on for major depressive episode where we do not have full response, but I do not have a personal experience with major depressive with psychotic features, and I would like to hear from other panelists what their personal experiences are. But I do feel, academically speaking, that this should show some promise.
Thank you, ma'am. My next question is to Dr. Arshad Hussain. Is Arshad here? Could he switch on his camera if he's here? Yes. Dr. Arshad Hussain is a professor at the Institute of Mental Health and Neurosciences, Srinagar, Kashmir. And so my question to you is, when we look at patients with post-traumatic stress disorder, sometimes these patients do have psychotic features, and we sometimes are a little reluctant to start a full, what I would call a fully matured antipsychotic like risperidone or opioid in these patients, because the profile biologically is more depressive. Now, would you think that drugs like cariprazine, because of their psychopharmacological actions and particularly D2, D3 actions, fit the bill to sort of help in certain psychotic and dissociative symptoms that you see in PTSD?
At the onset, thanks, Dr. Correll, for such a wonderful presentation. And thank you, Dr. Avinash, for inviting me for this panel. Look, as such, the evidence for atypical antipsychotics in post-traumatic stress disorder is at the most level 2, level 3. We do not have much evidence. But then on the other side, if you see about 30% of all prescriptions of veterans, Iraq veterans in combat had a certain, and atypical antipsychotic as used in them for the treatments. particularly the stigmatas which has been targeted in post-traumatic stress disorder with the antipsychotics have been assaultiveness, aggressiveness, severe re-experiencing, which sometimes smells towards psychosis. You are not able to differentiate whether this is psychosis and the re-experiencing happening. There have been some of the symptoms which have been targeted. My interest particularly has been in quetiapine, because quetiapine actually, the two drugs which have lots of evidence in post-traumatic stress disorder. One is trazodone and other is prazosin. Trazodone for the sleep per se and prazosin for actually the nightmares. Quetiapine actually combines both these things, and I have used in some of the post-traumatic stress disorder patients with good effect. For cariprazine, even though I have not used it, the serotonergic benefits of it and the 5-HT3, DC partial agonism effects makes it a candidate which could be tried, particularly smaller doses and at a lesser frequency, where DDCAR action takes, DDCAR, the metabolite action is more predominant. There does seem to be theoretically some role for that, but the time will tell us once we start using it.
Okay, thank you so much, Arshad. My next question is to Dr. Rakesh Banal, who is an assistant professor at the Government Medical College at Jammu. Dr. Banal, are you with us?
Yes.
So my question to you is, what has been your experience with? What has been your experience with cariprazine so far, and where do you fit it in the algorithm for schizophrenia?
I have been using cariprazine for more than around 1 year. My experience has been very good with the molecule. It's been a molecule. Hello.
Yes.
Yeah. I have used it in bipolar patients also, both manic and depressive patients, also in augmentation in depression patient, and some OCD patient also. It is a very good molecule in case of efficacy and side effect. Just a few days back, one of my patient who has been on cariprazine for more than 1 year reported back, and I did his lab investigations, and they were all within normal range. I had to shift him on cariprazine because of increase in serum prolactin level after he was taking amisulpride in around 100 to 200, I don't levels with mice. But his levels are okay today, and he has responded really well, and his father was very happy with the results, especially in the social adaptability of the patient. He had increased social adaptability, intercommunication skills, and communications were definitely very improved. These are few of he was on 6 milligram of cariprazine. Few of my patients are okay. But only problem one of the problem with cariprazine is EPS and akathisia. And the problem is that it stays a little longer. Even if you stop cariprazine, then because of half life is long, its metabolites is longer. It stays even for 1 to 2 weeks. That's a little problem. It's a wonderful molecule as such.
Right. Thank you.
Thank you, sir.
Thank you so much, sir. My next is to Dr. Puneet Kathuria, who's a consultant psychiatrist at KK Hospital, Ludhiana. So since you all do see so many patients with substance abuse in your state, and we have patients who may have a personality disorder component, either a borderline personality disorder component or a total personality disorder component with substance use, do you think there is any symptom-targeted management in personality disorders where cariprazine could be a useful molecule? Like we've used risperidone, we use aripiprazole, we use other molecules. But do you think is there anything specific where cariprazine might fit the bill? So you're not audible. Puneet, you're not audible, Puneet. No, we're not able to hear you. No, it's not audible. Puneet, give us 5 minutes. We'll come back to you. We'll just ask the next question and come back to you. You can, fix your audio in the meantime. My next question is to Dr. Ranjan Bhattacharya, who is a consultant psychiatrist at the Medica Ruby and Narayana Memorial Hospital, both at Calcutta and Berhampur, West Bengal. And my question to you is that, do you see any potential benefit of starting cariprazine in a patient with first episode psychosis? Do you think, a drug-naive patient, would you want to look at cariprazine as your first choice, considering its pharmacological actions?
Yeah, thanks, Dr. Avinash, for giving me this question and opportunity. It's a fascinating lecture, Professor Korel, I must say. So whenever a new molecule comes in the armamentarium of the management of any psychotic episodes, so you feel really thrilled and enchanted. It has been approved in 2017 in European Union, and in US it has been approved in 2019. So initially, when it has been launched in the Indian market, we had lots of promises. So cariprazine holds a true promise, as mentioned by Professor Korel, that it has a 5-HT1A agonistic action. That's a unique one, and like the ABC, the aripiprazole, brexpiprazole, and cariprazine, as well as the lurasidone and paliperidone. These are the wonder molecules that revolutionize the therapeutic aspects, especially when you consider about the negative and the cognitive symptoms. Yes, initially I have tried this molecule, but I was very skeptical because initially I was fast titrated, as mentioned, from 1.5, 2 days after 3, then 4.5, then 6, like that. But unfortunately, those patients develop akathisia. What I did at that, I initially added propranolol and clonazepam combination for a few days. So initial few days when I used this propranolol and clonazepam, those akathisia part has been tackled very easily, and those patients get compliant. Later, I have slowly titrated the outpatient every weekly interval 1.5 doses. Now, one thing I must confess here, that in two clinical scenarios, apart from managing the schizophrenia or the bipolar disorder, even bipolar depression because of a 5-HT1A agonistic activity as well as 5-HT7 receptor antagonism, as mentioned. But I have found in the management of the borderline personality disorder, those patients who are having high impulsivity, it holds a real promise. I have tried around 10 odd patients, and it's an antipsychotic molecule in the women in childbearing age group because it doesn't elevate the prolactin, it doesn't cause weight gain. So it is a wonder molecule, and I have tried those patients and it has reduced impulsivity significantly. Another group of patients I have tried is the substance-induced psychotic disorder or substance-induced mood disorder. So it has also hold true promises, and I very few patients are now I'm getting developing akathisia or restlessness or any changes or any other gross adverse effects. So instead of being skeptical, I think that in Indian population we can try in a slow titration. And maximum dose I have tried is 4.5. As I mentioned, the 6 milligram is the optimal dose, but in some trials, 12 milligram dose, up to 12 milligram dose has been tried. But I found it is quite satisfactory at a dose of up to 6 milligram. And in first episode psychosis, yes, it has been tried, but unfortunately, the first line option, very few. Only those cases when it is not responded to other drugs, it is worth trying. I have tried 1 or 2 patients of first episode of psychosis, but unfortunately those developed akathisia, and I truly confess that I didn't hold for too many long time. As we know, the Indian patients are very restless, and the patient family members will get very apprehensive why these patients' psychotic episodes are not getting control and they are developing restlessness. So that's the answer from my part. Over to you, Avinash.
Thank you. My next question is to Dr. Varsha Vidyadharan. She's an assistant professor at the Medical College, Kozhikode. Ma'am, where do you see the role of cariprazine in the management of negative symptoms in schizophrenia? Do you think certain negative symptoms that don't respond to other drugs, we try out even antidepressants, we try out aripiprazole, we try out low-dose amisulpride. Do you see any role of cariprazine in that group?
Good evening, everyone. Thank you, Professor Correll, for such an enriching data. As Professor P.N. Suresh Kumar sir has rightly pointed out, we, at least in Kozhikode, Kerala, has been struggling handling with the negative symptom part. Although we have a symptom control in the positive symptoms, handling negative symptoms is not that easy for each one of us. So whatever we have in our armamentarium is equally helpful for us. So having seen the molecular research part and the research evidence, it is promising and helpful, we hope. And we have been trying for few patients, and at least the good news is that there is not much sedation, unlike the other molecules which have been useful for the negative symptoms. So it is worthwhile trying, and let us be hopeful in this area as well. Thank you.
Thank you, ma'am. My next question is to Dr. Arun Nair. Sir is a professor at the Medical College, Trivandrum, and an honorary consultant psychiatrist at the Sri Chitra Thirunal Institute of Medical Sciences and Technology. Talking about drug combinations, sir, in your practice, I mean, do you see any role, any particular antipsychotic that you think would work very well in synergy with cariprazine? I mean, based on the psychopharmacological profile.
Yes, definitely, because most of our experience with related to cariprazine has been in bipolar depression as well as negative symptoms. So what I find is a combination of cariprazine with quetiapine has been identified to be very good in both these conditions. Especially quetiapine is one drug which has got some antidepressant efficacy even for major depressive disorders. Some research evidence is also there. So combining these two appears to be a very good choice, because quetiapine offers a little bit of sedation and cariprazine doesn't produce much such a problem. And also this combination is good from another point of view also, that this synergistic action does not produce much of a metabolic syndrome also, and even prolactin elevation and such issues are also not there. So I've tried this combination for bipolar depression cases. I've tried it, both of them, as add-on for resistant cases of major depressive disorder, also with psychotic symptoms. And I've also tried it for negative symptom prominent schizophrenia. And I find this combination really promising. Thank you.
Thank you, sir. My next question is to Dr. Roop Sidana. Sir is, of course, one of the senior most psychiatrists on our panel here with Dr. Nilesha. He is in charge and director of the Tekchand Sidana Memorial Psychiatric Hospital and De-Addiction Center, Sri Ganganagar, Rajasthan. So my question to you is a more philosophical and clinical one. I mean, you've seen antipsychotics come through the years and go much more than we have, right from the typicals to the atypicals to cariprazine, even to clozapine, which of course stands out a little different. So do you think cariprazine is like an Indian Premier League player which will come for a few years and go? Or do you think it will, remain etched in our minds like Sachin Tendulkar? So you have to unmute yourself, sir.
Thank you, Dr. Avinash. And thanks to Professor Correll for enlightening us on the various aspects of cariprazine. Avinash, you have just touched my heart. Whatever was going on in my mind over the last, when the panel discussion was going on, that I have seen many molecules coming with a bang. Like today we are seeing cariprazine, and some of them have lived to their expectations. Some of them have died down or just gone over the honeymoon period. And I'm still skeptical how this is going to come, cariprazine. And I have seen the olanzapine, risperidone, aripiprazole, paliperidone, iloperidone, and each, I used to attend the APAs, and each 1 or 2 years, there would be a new molecule, and it would come that now we have got the answer to our difficult patients. But I don't know. I have in practice tried cariprazine for bipolar depression with satisfactory results. Initially, akathisia was a problem, but slow titration and addition of benzodiazepine for a few days has helped. I have used cariprazine for residual symptoms in schizophrenia, negative symptoms. Still, I have not had satisfactory results, but it's too early to say, to comment. We are still in the waiting phase for those patients. I have not used it for mania. I think the kind of patients I treat in my practice are very different, and they need the atypical antipsychotics in high dose, or sometimes even haloperidol to control their symptoms, because they come in with the acute excitements which are very difficult to wait for long period or slow titration. And I hope we have a good future for cariprazine in the molecule for negative symptoms of schizophrenia and major depression, where we have psychotic symptoms along with depression. I have used in few patients where it's a major depression with psychotic symptoms in addition to antidepressant. It has helped them a lot. Thank you, Dr. Avinash.
Thank you, sir. My next question is to Dr. Manasvi Gautam, who is the director at the Gautam Hospital and Research Center, Jaipur, and an assistant professor at the JNU Medical College, Jaipur. Well, Manasvi, my question to you is very, very simple, that we use aripiprazole a lot in our practice, and sometimes patients complain of either sedation or weight gain, which is tremendous in the first few weeks and may settle or may not settle. Do you think cariprazine in the long run would be a suitable substitute for aripiprazole?
I think it has already started doing its job. Many people we have seen have shifted already from aripiprazole to cariprazine in that profile where we see cognition as an issue, alertness as an issue, where there are students or working population who need that alertness in the day. At the same time, they want this robust effectiveness with very small dosing kind of feature. So there it has already started working. I have also seen it working along with clozapine, and I've also tried it along with amisulpride for prolactin reduction. That way is also it's replacing aripiprazole, which we have used for augmentation for this prolactin thing. So definitely it's coming in. I won't say as a replacement, because every molecule has its own place and has its own very, very characteristic properties which suit to a patient population in particular. But definitely there it has made its own niche, and it is on now having its own population which responds very well to this drug.
Thank you so much, Manasvi. My next question is to Dr. Samiksha Sahu, who is a consultant psychiatrist and at the Bhopal Neuropsychiatric Center, and is also attached to the Gandhi Medical College, Bhopal. Ma'am, my question to you is a very simple one, that we sometimes are a little skeptical about using risperidone in young women because of its tendency to cause hyperprolactinemia. Aripiprazole in young women, because we feel that weight gain is sometimes it does come up. And we obviously, the gynecological side effects do worry us at times. Do you think cariprazine would be a safe alternative for, treating psychotic symptoms in young women between the age of, say, 15, 16 and above, and right up to 25?
So first of all, I would like to thank Professor Coral sir for such a nice session, and Dr. D'Souza sir for the lengthy moderation he's carrying on. So in practice, in theory, are two different. In theory, cariprazine looks like the super drug. Everything is there, no side effect. It's look like it is the best drug which has come up in psychiatry. But when it comes to practice, our hands get tied a bit. So if you're in a private practice, you worry that if some patient experience some side effect, they will switch to another doctor rather than coming back to the same doctor. But if you're working in an institution, you have this advantage that, okay, the patient will come back. So luckily, I'm getting the experience of both. And the initial experience in any group where I have used was like a lot of akathisia, which has happened in patients, and 1 or 2 patients has been dropped because of that. But over the time, when we get a little wise, so we manage that side effect. When it comes to females, the one thing is weight gain and the other thing is periods, and the socioeconomic strata mostly which I deal with. So they get really worried if the periods goes missing. They'll go to a gynecologist will say something, they'll stop your medication. So it's like an entire story which is there. So I feel cariprazine is actually a wonderful drug in females when we talk about prolactin, when we talk about weight gain, when we talk about other metabolic side effects. And especially in those cases of bipolar depression or borderline personality disorder, where we see a little bit more of a female, female ratio is higher in these kind of illnesses. So I feel it is theoretically a very good drug in those cases. And in my personal experiences, it works really well in bipolar depression cases, negative symptoms of schizophrenia, and few cases of cannabis-induced psychotic disorder. Because in Madhya Pradesh, we have seen a lot of cannabis use disorder patient and cannabis-induced psychotic patients. And I have used it in a couple of patients, but I've added propranolol and low-dose clonazepam or alprazolam in the beginning, and it has actually showed a lot of improvement in them. So overall, a good drug. We need to be more bold in using it. That is what my take is.
Thank you. Is Dr. Pawan Adatia here? Has he joined? Because I don't see him on my screen.
Yeah.
Oh yes, Pawan, you're here. My question to you is, one, your experience with cariprazine, and do you think it has any specific role? Is there any specific antipsychotic you think can be combined well with it?
Yeah, I've started using very recently. I've started with one patient with clozapine. It's actually too early to call to which antipsychotic we should add over. But we are in early phase, and I think with over the period of time, maybe 6 months, we would be able to know more with our experience, and also by sharing from getting information from more other psychiatrists. So it's too early to call on Monday.
Right. Well, thank you so much. Before we go to my last 2 panelists for the question, I'd like to inform everyone here that we have around 856 viewers who are online with us, and we have 130 who are seeing us on YouTube. That brings us to a total of 986. We have 14 panelists. Please ask one of your friends to join each who have not joined, so we'll reach that magic number of 1,000, and the webinar would look successful. But going on to Dr. Adarsh Tripathi, who is a professor at the Department of Psychiatry, KJMU, Lucknow. Dr. Adarsh, you all have a full-fledged department that works in geriatric mental health. And my question to you is, based on your clinical experience and work in your department, do you think in late onset schizophrenia or geriatric depression would cariprazine fit a bill as a good antipsychotic?
Thank you, Avinash, for this question. See, many of the reservations which we have with other antipsychotic during use in elderlies are not a reservation with cariprazine. That the issues of sedation, the issues of gait instability, the issues of metabolic side effect are of much concern with several other antipsychotics. Per se, see, cariprazine is still a relatively new molecule in our armamentarium. And in general, we have our reservations in using a newer antipsychotic in extreme of ages, like in children and elderly, we start using something. when we get a little more experience in those conditions. I am primarily using cariprazine in adult population as of now, and my experience has been mixed. As I would say that with the advantage of using aripiprazole for quite some time, we have seen that people's use of aripiprazole has significantly altered. That initially people were not having a lot of difficulty in using aripiprazole, but later on we got to understand that how to use aripiprazole safely, and now we know that it is one of the highest selling molecule in the antipsychotic in the world. Cariprazine is also taking off, and I'm able to find out that in bipolar depression, mild to moderate severity, in new relatively milder or low-grade psychosis where there is no much agitation and severe aggression, in those kind of cases, cariprazine is a very useful molecule. Elderly, still my experience is not in a large number of patients. I'm not using elderly and children and adolescent. I'm still weighing my response in adult population unless I'll be having a good experience. I hope that we need, I myself need a bit more time in addressing. And one more thing that with aripiprazole, what we have seen that we have much more dose flexibility right now. That we had started with doses of 5 mg to 15 and 30 mg, and now we have 2 mg preparations, or we are having tablets that we can break and use in that way. Cariprazine is available in capsule form, all formulation in India as of now. So the more dose flexibility that might be needed in future is not available to us as of now. So that might be seen by pharmaceutical industry. It might be helpful in increasing its prescription base.
Right. Thank you so much, Dr. Adarsh. Well, Dr. Puneet is back. He was having audio problems, but I think Sir is back. And Dr. Puneet, if you're here, my question to you is, do you see any, since you all see a lot of patients with substance abuse in Punjab, do you see any specific use of cariprazine for targeted symptoms in that group? Sir, again, we are having audio problems with you. I don't know why. Maybe the gods don't want you to speak to us. I don't know, there's something wrong about it. So what you could do is, I think, just WhatsApp me what you want to comment. I'll read it out. I'll do that. Just WhatsApp me. Yes, thank you so much.
Or put it on chat.
Or put it on, no, WhatsApp me. That's better, because in the chat I'll get interrupted in between. The WhatsApp is better. Our last panelist is Dr. Sandeep Antil. Is Dr. Sandeep here? He isn't here. So anyway, I will now. Yes, sir.
Dr. Sandeep had put his comments in the chat box.
Yes, sir. That I'm coming to. I think Dr. Sandeep, by mistake, has joined the viewers link rather than come to the presenters link. So he isn't here. So there are two questions for you, Professor Correll, and I will just ask them. And then there are two questions that I want to ask you, because everyone has spoken and I haven't got a chance to speak. One is that how is cariprazine different from aripiprazole in terms of clinical efficacy and achievement of remission in drug-naive patients? This is a question by Dr. Vaibhavi from our group. So your comments, Dr. Correll.
Yeah, I mean, we don't have really a first episode study with cariprazine. In my hands, both are fine partial agonist drugs. There may be better efficacy for primary negative symptoms that we can see in first episode patients. But again, it doesn't help for everyone who has negative symptoms either. And there's a little bit less partial agonism. So for some patients where it might be too much partial agonism with aripiprazole, you don't get the full efficacy. There might be a little bit more room for going up with cariprazine. I like the longer half-life so that patients can miss a dose here or there. I think that is a distinguishing factor. And it would be nice to see more of a first episode sample with cariprazine. And I mean, you have so many patients in India, maybe you could get an investigator-initiated grant, even if it's open label, and then compare indirectly some of the effect sizes. So that here we have all panelists together. You have centers, maybe you can get some initial funding and do something like that.
Well, sir, if you, I mean, we'll probably write to you, and if you guide us, we'll definitely initiate, I think, a study in that regard from all of us.
Sounds great.
Question from Dr. Sandeep Antil, who's also a panelist. He's here now. But before we go to him, the question to you is, can cariprazine cause diarrhea or gastric discomfort in patients? Because he's seen it in around 5 to 6 patients having similar symptoms.
Yeah, it's interesting. I have not seen that in terms of maybe diarrhea, and that's unusual. Maybe there were other medications on board, maybe it's unrelated, but it's not a particular side effect I would have seen or predicted.
Dr. Sandeep, he is a consultant psychiatrist at the RB Minds Care Center, Sonipat, Haryana. Well, Dr. Sandeep, please share your views. What would you like to tell us about cariprazine?
Thank you, sir, for giving me this opportunity. In my opinion, sir, cariprazine can be used as an add-on or adjunctive therapy in case of schizophrenia, not as on a first-line treatment for schizophrenia. It can be used in case of, I think, in bipolar depression, as an add-on therapy for along with OCD patients, somatoform patients, delusional disorder patients. Not like it's not a main drug for psychosis. I don't think so. My opinion might be different from other persons. Thank you.
Yeah. Dr. Puneet, who we lost out to audio, has sent in his comments that he feels stubbornness and aggression are 2 main symptoms in substance abuse populations where he feels with a personality disorder component that cariprazine could be of use. And of course, he says one of the most versatile antipsychotic molecules we've had of age has always been olanzapine. Dr. Correll, my question to you here is that over the years, we've had so many drugs, and you in your experience have also seen so many drugs come and go. I mean, we're so comfortable with risperidone or olanzapine or quetiapine because I think we've used it in far more patients. And the same goes for probably aripiprazole. Why is it sometimes that, some antipsychotics come and just stand the test of time, and some just come and wither away? I would like your opinion on that.
Yeah, I mean, this is a tricky question. I think some medications have not had added value, like iloperidone or arsenipine. They've come and gone very quickly. Where's the niche? What's different in terms of either efficacy or safety? And that if there's not much of a distinguishing factor and they come with not more benefits on efficacy, but yet another side effect profile, or that we've already resolved with other medications, the risk benefit doesn't point towards this being a go-to drug, then I think those leave the scene rather quickly. I think olanzapine has been studied in so many different conditions. There was a big muscle behind it. Lilly did a good job in that sense. Patients seem to like it despite the weight gain. There's something, whether that's the anti-anxiety, the antidepressant, or the calming effect. And it took a while for us to get other medications that don't have these side effects and us also liked. And I think partial agonists will not leave the scene. They have some dopamine tone benefit for some patients that are more active. They're all antidepressant. Having an antipsychotic that is also an antidepressant is helpful because depression drives down quality of life. Where if you have low quality of life, there's suicidality, there's also low functioning. So there needs to be some benefit for clinicians or for patients. I think that's the key here. Yes.
Well, sir, there are 3 questions, I think, before we come to the end of our panel here and our event for the evening. What is your recommendation for use of cariprazine in first episode psychosis as a monotherapy? Do you think it has any efficacy there? And also in pediatric populations, do we have any experience?
Yeah, so I mean, any drug that is pretty safe can be used at the extremes of age. That has already been pointed out. So there are ongoing studies in adolescents. I've used it in adolescents, and it's quite well tolerated. Also outside of schizophrenia, like for eating disorders, for example, where there have been akathisia episodes with aripiprazole, but not with cariprazine. So I mean, that's also possible. First episode, 80% of patients will respond. There's a 20% primary treatment resistance group, but there's also an 80% group with that person responds pretty well. So here, having an agent that has relatively few side effects and doesn't shut down dopamine too much is, I think, a go-to medication. And cariprazine monotherapy is certainly something one could try.
Right. So my last question to you before we come to the end of this panel is, we've always used clozapine for treatment-resistant schizophrenia, and there has been a bunch of literature that has come out about patients that respond either 50% to clozapine, or even those who sometimes don't respond to clozapine. Do you think in those patients currently, because we probably used all other drugs and they are on clozapine but responded 50 or 60%, do you think adding cariprazine would add any value?
Well, there are case reports that this is the case, so we can try. There's the Finnish data we published with Jari Tihon that a partial agonist, in that case aripiprazole, which was only available in Finland, was superior to clozapine monotherapy when added together. There's also some reduction in weight when aripiprazole was used. So having cariprazine with a similar mechanism of action, that's certainly something one can try. And we've overestimated the efficacy of clozapine for negative symptoms. So maybe here in the combination, there could be certain benefits. But again, it would be great to have a larger sample, and maybe you can get this together, or even do an RCT comparing augmentation with cariprazine or placebo. That would be really helpful for the field.
Yeah. So one last question before we end. Your personal choice, cariprazine for schizophrenia or cariprazine for bipolar disorder?
I don't see why I have to make a choice.
Right. So you would recommend using both?
Well, yeah, I mean, it's a medication that has efficacy in both, and you can find the right patient for the right drug, and it's certainly one option. So I wouldn't just box it into one area.
Yes. I think that brings us to the end of today's panel. We've had a lot of learning about a molecule, and I think about pharmacology in general. I want to thank each of my 14 panelists who come from different corners of the country, for being here throughout the panel and bearing with, such a long panel. I would like to thank Professor Dr. Christopher Correll for such a wonderful lecture. And I would also like to thank you for being here throughout. And you've come, I think, 7 seas away from us. So we're very thankful for that also. Well, at the end of this, I think we've had our experience. We'll go back, we'll try the molecule, we'll probably come back in around a few months, share some more experiences, and I think that's how we learn. So let us all use cariprazine in our practice. It's been wonderful moderating this panel. Of late, no one wants me as a panelist. They're more happy to have me as a moderator. So I think I'm fine where I am. Yeah, yes.
I think you've forgotten Dr. Nidesh Shah to...
Yeah, no, Dr.
I think last word.
No, I can't forget him. He's my boss at Sion Hospital. I can't forget him. So yeah, I'm coming to that. So I said, I'm very happy to be here as a moderator. And I think we'll save the last word for Dr. Nilesh Shah. So what would you like to say before we go?
Yeah, I would say what the last question which you asked, whether it's for schizophrenia or for bipolar, there is a site called drugs.com. where patients put up their own reviews, that what did they like the medicine, what were the side effects, etc. Cariprazine was approved for schizophrenia in 2014-15. So since more than now 7, 8, 9 years. For bipolar, it was approved in 2019. If you see the reviews for schizophrenia, there are about 100 reviews. But if you see for bipolar, there are 300 reviews. So for schizophrenia, in last 8 or 9 years, there are 100 reviews. For bipolar, in last 3 years, there are 300 reviews. So it tells us that probably people, the psychiatrists and the patients, are preferring more for bipolar depression rather than schizophrenia, But yes, obviously, it looks like a good molecule, particularly in negative symptoms schizophrenia, for negative symptoms as an add-on medicine, and also in bipolar depression.
Right. Well, thank you, sir, for those comments.
And the last word, which I always put up a slide before or after, घड़ी detergent टिकिया, पहले इस्तेमाल करे, फिर विश्वास करे. So I think we are all using it.
I totally agree that yes, we will use it, then we will know how it works. So I thank our panelists for being here. We thank our pharma sponsors for the excellent facilities provided. And I think that brings us to the end of this panel. It was great connecting with all of you. Good night and God bless.
Good night.
Good night.
Yeah, good night.
Good night, sir. Thank you all. Thank you very much. Thank you.
Thank you. Good night.
Thank you, sir.
Thank you very much, sir. Been a grand success. Thank you.
Yeah.
Great.
Thank you, sir. Thanks a lot. Ronak, please do the needful.
Sir, allow 10-15 seconds because YouTube पे live थोड़ा delay चलता है. So allow me 10-15 seconds more so that the session gets completed.
Okay.